Thank you all so much for coming on behalf of our whole panel. We're really humbled to be your first introduction to the Ideas Festival. I'd like to start by introducing the panel. Robyn Calder is the executive director of ELMA Philanthropies. ELMA invests in organizations that are focused on improving the lives of children and communities, particularly in Africa. They have a focus on African-led education and healthcare solutions. Panjabi, next to me, is CEO of Last Mile Health, which works with governments to deploy high-performing national networks of community health professionals who provide life-saving primary health care to the most remote communities, and he'll talk more about that, where those communities are. And on our far end is Josh Nesbit, who is CEO of Medic Mobile, which is a nonprofit technology company focused on advancing global health equity. And specifically, Medic Mobile builds free, open source software that supports the health workers that Raj will talk to you about, who are delivering healthcare in the hardest to reach communities. We're at a time where a lot of energy is spent on what makes us different. So I asked each of our panelists before we started what makes them tick, what they're passionate about. And it's a reminder that people from very different parts of the world can be united by passion. So Robyn is most passionate about her ability to support change makers who are working in Africa. Raj is most passionate about digital innovations that are leading to higher quality healthcare outcomes. And what really makes Josh tick is this tremendous inspiration he derives by seeing health workers do everything in their power to care for their neighbors. And you will hear so much of their shared passion in this conversation that we're about to have. They also share a lot in common in their reading habits. Robyn is reading The New Jim Crow. Raj is reading Just Mercy. And Josh is reading Health as Liberation, Medicine, Theology, and the Quest for Justice. Robyn is also an expert in the Llama Llama series of children's books, so don't be afraid to ask her about that. So I've been accused of being a pathologically positive person, so I'm going to start with some great news for you. Then I'm going to bring it down a peg and give you some reality check, and then talk to you a little bit about enormous opportunity. And from there, we're going to get the panel started. So what's the good news? Generosity is on the rise in America. According to Giving USA, we had the highest giving year ever last year, with $400 billion of philanthropy flowing into the world. There is extraordinary generosity at play. We have 14 more billionaires who have signed the Giving Pledge, raising that number, which was 40 in 2010, to 183 people who have pledged to give. That's right, it's incredible. And we are in the middle of experiencing, I'm going to say this number and sort of hold on to it, a 300 trillion, yes, that's T, trillion-dollar wealth transfer between baby boomers and millennials. And in that wealth transfer, you are seeing new people come to the philanthropy table. So what could possibly be the bad news in that kind of a scenario? So here's the bad news. A lot of money is still sitting on the sidelines. There is enormous potential in giving that has yet to be unleashed. And when big bets happen, the big bets that we're going to talk about today, they disproportionately are flowing to wealthy organizations. They are flowing to universities, to hospitals, to institutions that are very well established, instead of flowing to organizations that exist for social change. And so what is it? Where is that disparity when you have so many people who pledge to give their money away to improve the world, and yet it's not necessarily flowing to the organizations that are on the front line of that change? So given the great news, given some of the reality, what's the opportunity that we're going to talk about? The opportunity is, if big bets can play such an outsized role in social change, how can we activate more? And that's what the conversation is going to be about today. So with that, panel, let's get started. I thought it might be helpful, Raj and Josh, if you guys would just talk a little bit, for starters, about your work. What do your organizations do? Who do they exist to benefit? And what social change are you seeking to create in the world?
Sure. Well, thank you. It's such an honor to be here. And so I lead Last Mile Health. I'm a physician by training, and our focus is really very simple. It's to bring healthcare within reach of everyone, everywhere. So it's simple, but it's big. And it's urgent now because we know that despite living in an age of medical breakthroughs, and I also teach at Harvard Medical School, and I know how many breakthroughs are on the frontiers of modern science, still today there are about 8.9 million people, children primarily, but mothers and family members, across developing countries that are dying from preventable and treatable diseases. And this is something I've come to see firsthand. I grew up in West Africa, in Liberia. My parents migrated there from India. And when a civil war happened, my family fled to the United States. I was resettled with my family in North Carolina. Probably my first interaction with philanthropy was to be taken in as an immigrant. I had the chance to have some scholarships, go to medical school, and I went back to Liberia to see if we could serve the people we'd left behind. And when I got back as a medical student, at the age of 24 in 2005, just saw utter destruction. We had 51 doctors, 51, left to serve a country of 4 million people. That would be like San Francisco having 8 doctors to serve the entire city. So I was seeing my patients die in rural, remote areas because they weren't near those few doctors that remained. If you got sick with a fever, you might have malaria, which kills many of those kids that are dying from preventable and treatable diseases. And the only way to get your daughter a diagnosis would be to put her in a canoe, get to the other side of the river, and then walk for up to 2 days, in some cases, in the rainforest to get to the nearest clinic. So we live in an age of medical breakthroughs, and we've made some impressive ones, and they're extending life expectancies all around the world, but not in these remote rural communities. They haven't reached the last mile. So how do you solve for that when you have such a massive shortage of doctors? We are short about 7 million health workers in the world now. We will be short 18 million health workers by 2030 if we do nothing more. And we can keep training doctors and nurses, and we need to do that, but we've got to do even more. So what Last Mile Health does, and Josh will speak a bit on the technology side, is to actually hire, train, and equip people from these rural communities. Women like Serena, who was 10th grade educated when we met her, lives in a rainforest community. It's about 6 hours from the nearest clinic, about 500 people in her community. Never had a job, but can be trained because of the advances we've made in training people and skilling them up in medical care in 30 life-saving skills that can take on treatment of malaria in her community, like the little girl I just described, to supporting women who are pregnant, to ensuring that people with HIV or high blood pressure get the treatment that they need. 6 months, paired with a nurse to coach and train her that comes to her village, and importantly equipped with a smartphone and given a job to do this, about $70 or $80 a month. And Serena has managed to stop child deaths in her village completely. So we were at this for a while, and I think one of the things we're talking about is what's the role of big bet philanthropy in these models, in these big opportunities for change. Well, I started our nonprofit with my wife and community health workers about 10 years ago. I was a physician, I wasn't an entrepreneur. I didn't know too much about building business plans back then. And we were getting married. We asked all the people at our wedding to, instead of giving us gifts in the registry, to give us money for the startup. Opportunistic, romantic, whatever you want to call it.
China's overrated.
Exactly. We raised $6,000. In 10 years ago, we may have been at maybe a few $1 million a year of budget. We were training a few hundred workers to serve a few thousand people. Enter this opportunity with something called the Audacious Project, which is one of the collaborations that Robyn and Lindsey at Elma and Skoll, along with Virgin Unite and Children's Investment Fund, has been working with us on. Thanks to Ted for pulling this together. They asked us to put something bolder together that could train and equip thousands of workers. we couldn't take on that problem alone. And that's usually the case with these big problems. So we were teamed up with our friend Chuck Slaughter at Living Goods in East Africa, trying to do similar work. And we bonded together to create a plan. And the plan involved investing more in workers like Serena, teaming up with governments to support them to scale up these workers. We were joined by UBS Foundation. Phyllis is here from UBS in the audience. And we put that plan together. And 6 philanthropists, those 4 and 2 who are anonymous, put up a $50 million challenge grant, pooling their resources together and saying that for every dollar you raise, we'll add a dollar, up to 50 million. Well, that plan is now allowing us to scale up. Our goal is to get to support Uganda, Kenya, and Liberia, and 2 to 3 additional countries in Africa, to scale up and support 50,000 digitally empowered community health workers like Serena to serve over 30 million people in the next 4 years. And that could not have been possible. So when we take on these big challenges, almost always, whether it's universal health care or it's the car seats that now all our kids use, kindergarten, a universal 911 service, every one of these seem like they, in retrospect, like they were inevitable, but almost every time it was a moonshot at the time. Getting healthcare within reach of everyone everywhere is one of the moonshots that we need to take on today. And it just wouldn't be possible if philanthropic leaders like Robyn, Lindsey, and others here weren't pooling their resources to make that more possible. So it's transformed our organization, and a big part of it is technology.
Yeah, I mean, I think when you talk about moonshot, it makes me think about Josh immediately, because your work would not be possible without his vision. Maybe you could tell us a little bit about what you're doing.
Thanks, Lindsey and Robyn. It's an honor to be up here with these panelists, and just wonderful to be here with you all. I have to say, talking to my peers, and Raj included, I'm struck by how many of us are drawn to this work because we saw that we were systematically excluding people who were poorest and furthest away. And the unjust global system and health systems needed to be redesigned. I saw that when I was in Malawi working alongside a single doctor responsible for 250,000 people. Patients were walking 100 miles to get to him. That system needed to be redesigned. The patients knew it, the doctor knew it, and the community health workers knew it. And for me, if you stop an American on the street and you ask them to describe a health worker, they'll paint a picture, right? There's going to be a white coat involved. I had to rethink who I thought of as a health worker and who we supported as a health worker and how that health system functioned. And once we get that right, I think we can figure out a role for technology. Once people paint a vision for how that system is going to get redesigned, then technology comes in as a servant. And it was right around the time that mobile coverage was spreading across Africa and Asia, we had this opportunity. And we founded ourselves as a purposefully weird nonprofit tech company to build things that otherwise wouldn't exist alongside these health workers, and then figure out scale and reach. And if you fast forward a lot, working with really an amazing coalition of partners, we now support 20,000 community health workers, and they go door to door every single day caring for their neighbors. The app guides them through diagnosing a sick child. It lets them know which families they need to see that day. It shows them the progress that they're making, connects them to a support team. And collectively, every month, they're providing care in over 1 million home visits. Over the course of this year, they'll care for at least 2 million sick children. I would frame a challenge for us here and for philanthropy is how we go from millions to billions. Yeah. And could not pick a better crew to work on that with.
Great. So let's actually, this is a great setup. So let's talk about how philanthropy has traditionally worked, both from the grant giving side and the grant recipient side. And when we're talking about big bets, how is that different and why is it necessary? So walk me through maybe what, when you were first getting started, it was like to interact with philanthropists. And then maybe, and I think you just sort of said it, right? The challenge is how do you go from millions to billions? But maybe give us a little bit more about why now is the time to be rethinking philanthropy.
Well, I think what it was like back then, I mean, you can imagine, when we started in 2007, we had that $6,000. We were able to train, I think, about 20 community health workers in the back of a garage. I was spending my resident hours working at the hospital and training at Mass General Hospital, and I'd have attending doctors come on in the emergency room, and in between patients, I'd write them an email and ask them to donate $25, $50 to our campaign. So it's hard work to do that. I think that we were fortunate. Sandra and Sam Tyler are here. They organize a global neighborhood fund, a family fund. They were one of our first grant givers and helped us move a little bit higher. It let us get a little capacity, helped us hire our first staff in the US. But it wasn't until about 4 or 5 years in that we had the chance, when we had some data around the impact of this model. And we were able to show that you can increase by training Serenas, equipping them with smartphones like the ones that Josh and his team are working on. You could actually increase treatment for children by over 50% in rural areas where they didn't have it before. You could see, as Chuck Slaughter and Living Goods is showing in Uganda, you can cut child mortality by over 25%. It wasn't just our groups, but a sea change of others that were saying, look, this is possible to do. It is possible to bring healthcare within reach of everyone everywhere, but we need a global army of community health workers to do that. So it was a combination of the science from our sites and the science that was happening everywhere else that now has put this moment forward where we are seeing not only is this important, the right thing to do, it's always been the case, not only is it better for the economies of the world, if we have more people who live longer and have productive life years, there's more opportunity for growth. But importantly, we know from the recent Ebola epidemic that affected my country and is now affecting the Democratic Republic of Congo, but also had spread even to US shores when it happened in West Africa, that healthcare blind spots anywhere affect those of us anywhere else. From a village in Liberia to a city in Dallas, which is where Ebola transferred, as some of you will remember, it's possible. So we know there's an urgency morally, economically, and now because of the safety of the globe. But the science is also really great. 30 services, if expanded to 90% of the people in the world who need it in rural areas, could save 30 million lives by 2030. I mean, that is 30 things that we already know can be done by Serenas. And that's a pretty big, exciting vision to get behind. So that's why now is really important. But we need a number of countries and supporting them to get, between Africa, Asia, and the Americas, to get to a certain critical mass. And we're working together now in Africa to support that effort.
Robyn, so as a foundation executive, maybe you could share what your experience has been like in seeing how philanthropy is starting to transform. What did it look like when you first started your job, and how are you seeing it differently now?
Sure. So I think one of the features of traditional philanthropy that you described, where individuals or organizations are giving to institutions that they have some familiarity with, whether religious or academic, that's largely been about charity and grant making. And I think what's exciting about so-called big bet philanthropy is that it's an evolution of philanthropy away from just giving grants to solving problems. So in the case of the work that Last Mile Health and Medic Mobile are doing, they're trying to solve the problem of access to universal health care in the context of extremely low resource settings. So from my experience at ELMA, what's been so fantastic about this big bet philanthropy and kind of what's unique about it is that it's largely team-based. So what you're seeing, kind of the other side of the coin of big bet philanthropy, is collaborative philanthropy. So when we're looking at Last Mile Health's plan to expand to 50,000 community health workers, we're doing that with 5 other philanthropic organizations. And what that means is that ELMA, who has actually been supporting Last Mile Health and Living Goods for many years in a small way, we're able to put up even more capital because we're doing it in a collaborative way. So in a way, the risk to our capital is mitigated by doing it collectively. So if Raj came to ELMA and said, we need $100 million to scale up our work to 50,000 healthcare workers serving 34 million people, we'd say, wow, that's amazing, but we don't have the capital to do that. We're not going to take all that risk on that one ambitious program. But by doing it in a group, we're able to share the risk. We're able to take on these bigger problems that we're facing as a world today.
Yeah, I'll add one comment. Just I'm sort of going to straddle two worlds here as moderation and speaker. I'm on the board of the Skull Foundation, and I think there's also a settling in of, and I think Jeff Skull has always been an enormously humble person, but a real humility and appreciation that even if we are maxing out our resources as a foundation, the challenges we seek to solve are so big. And that if we don't do it in a team-based way and start pooling resources, we are holding back the very change that we seek to effect. And so for us, it's everything that Robyn has said. It's shifting from individual grants to this problem solving, but really embracing the idea of what will it take to actually start ending things, to completely change a status quo, to lift someone out of a vulnerable category, to grow a workforce. And we alone, we just can't do that alone. And we don't want to do it alone.
It's more fun.
It's
to do
so
it
much
together,
more fun.
isn't it?
Yeah, I mean, so we all work together, and so like on top of all this, I can tell you, solving problems at the scale that Raj and Josh talk about. I mean, they see desperation daily, and the courage and ambition they have to end that desperation is extremely motivating for us. But to do it and start to really become friends in this challenge is also something, it's an unanticipated side benefit. But I think when you're working with people you trust and you're having fun, it ups the ambition quotient almost immediately.
If I could just add too,
Totally.
Lindsey, that one of the benefits of doing philanthropy together in a group, it's fun. You get leverage on your own philanthropic investment. So if you put $10 million and 9 other philanthropists put $10 million into a $100 million program, you're getting basically 10x on your investment, which is fantastic. But also, your philanthropy is better. So Elma's philanthropy has gotten better by doing it in this team-based approach. And I'll give you another example of a big bet we're taking with a group of philanthropies that includes the Children's Investment Fund Foundation, Virgin Unite, Bill and Melinda Gates Foundation, and ourselves, Elma. And basically, we're pooling funding to support an organization called Sight Savers that's going to work to eliminate trachoma from all of Africa. And what trachoma is it's a terrible disease. It's passed by flies. More than 200 million people are affected by it, and it causes an incredibly painful. It's incredibly painful and can ultimately lead to blindness. But like some of the things Raj has been talking about, we know how to get rid of trachoma because we've gotten rid of it in the developed world. So those 200 million people affected by trachoma are all in the developing world. We know what it takes to get rid of this disease, to eliminate it forever. All it takes, literally, is pooling our financial capital. So in this funder cohort, we're not only pulling together our capital so we can take on this massive challenge together, but we're benefiting from each other's, from the core competencies and expertise and experience that each philanthropy in that group has built up over time. So for example, the Bill and Melinda Gates Foundation bring a huge amount of technical expertise in the area of neglected tropical diseases. Trachoma is a neglected tropical disease. They bring that to the collaborative. The Children's Investment Fund Foundation is known for a cutting-edge approach to measurement and evaluation. They bring that to the partnership. Virgin Unite and Richard Branson brings their skill set in promotion to the partnership. In the example of supporting Raj and Last Mile Health and expanding community health workers across Africa, the Skull Foundation brings their skill set around convening. So it basically leads to a situation where the whole is greater than the sum of its parts. We're not just getting financial leverage, but we're actually, what we're investing in becomes better because we're doing it in a collaborative, team-based fashion.
Yep.
Yeah.
So Josh, I want to start with you, and then Raj, please join in. I've been trying to imagine what it feels like when someone bets on you. I remember being hired by Jeff Skoll, and this overwhelming feeling like, how is someone so important in the world betting on me, right? To help him see through his vision in the world. And that's in an N of 1. I'd love for you to reflect on, as an entrepreneur who's trying to affect social change, what does it feel like when a group of people come together in belief of your idea? How does it change your aspirations? What does it do in terms of how your team works? Maybe just some reflections, and then what I'd love it if you could do is share a very specific story about something you can do now that you could not do 2 or 3 years ago.
It's an awesome question. It makes me think of studies about stress, actually. And I forget who did the research, but maybe 10 years ago, people were convinced that stress was toxic. And that there was a wave of, I don't want to say stress hysteria, but along those lines, right? Avoid stress at all costs. And then new research was done that showed that actually it's not stress, but the gap between the challenge and the skills and capacity that you have to address it. Both your perception of your capacity to address it and the reality. And if I think about myself and peers and Raj and Chuck and others, being bet on, it's as much the idea as us. And really, the way I view it is they're betting on the community health workers that I know so well. And to me, that's the safest bet that humanity could make. But it also means that we can, across the board, times tens of thousands and then millions, bridge that gap and relieve stress in a global system that then relieves stress for that health worker every day, and then relieves stress for the mother with a sick child who's really concerned right now about what to do and is alone. And so it's that cascade that I think is beautiful, that starts with the bet.
Yeah. You talking about stress reminded me of just when I first came to this country, and you think about everything that's going on with immigrants now in the country. We were benefited as immigrants when this country is at its greatest, living up to its values, willing to take people in, willing to invest in them, willing to help them live up to their full potential. What happens, the kinds of things that happen to my family, is my dad came here with no experience in how to run a business in clothing, and somebody bet on him with $10,000 to start. Didn't have the best branding, New York Styles in Winston-Salem, North Carolina, as a clothing shop, and he went on the radio and as not as Ramesh Panjabi, but as Crazy Ricky selling crazy deals. I mean, he was just trying, and that's what all of us try to do at the times we feel the most stress, right? But he made it, and he got his kids into school, and now he gets to go back to his passion, which is wedding filming. I don't know how all that got together, but I think, Josh, what you said is so important, because I think any of us could relate to this. You don't have to be a social entrepreneur. But if President Sirleaf, the first African woman president, some of you will have known, I think she's been here at Aspen, who just won the Mo Ibrahim Prize and also previously won the Nobel Peace Prize, she once said to us that if your dreams don't scare you, they're not big enough. And if you really think about the number of times you or your kids or your relatives have tried to pursue something that really was a big dream, whether it's trying to work on healthcare like we all are, or it's just trying to start a business, you have this scenario, and it was an article in Inc. a few years ago that said this. It's like riding a lion, and everybody looks at you, and it's like, wow, that person's really doing a great job riding that lion. You're on the line. You're like, how the hell do I stay on the line and not fall off? Because it is hard, and it's so when someone bets on you, what a powerful gift to be this relatively early in our careers with our teams. Both organizations about 10-ish years old, if I can say that, a little more than 10. We've each been in 1+ decades. We probably each have 3 decades, God willing, towards this fight. But to be bet on this early really shifts your ability to dream. It lets you ask more questions. It makes you feel more confident. And I think that is one of the greatest gifts from all of this, is exactly that.
Great. Okay, so across the board now, for each of you, one thing that you can do now that you could not do 2 or 3 years ago as a result of being either sort of bet on or making the bet?
Such a good moderator. We'd never answered that question. Good, yeah.
I mean, I'll start and somewhat, forgive me, a little bit abstractly, but bear with me. I think if you talk about getting from millions to billions, mathematically that's 1,000x, right? So let's look at the dimensions, and Raj and Ari and Chuck and a handful of others have spent decades building on decades of work from Partners in Health and others, showing that we can 10x the access to care in a unit, in a community, right? We've shown and proven that dimension. We've shown that we can recruit more health workers and rethink who we think of as health workers, and 10x the number of health workers that are recruited and trained in a unit. There's a really tough dimension of scale, and we know that scale is achieved in deep, true partnership with governments. And for us to be true partners to governments, we need meaningful resources to move the needle for them in really big systems. So what $100 million does is bring meaningful resources to that partnership to then accomplish systems change and use those other 10x's to get closer and closer to that 1,000x.
So if I'm understanding right, I mean, one of the values that you're articulating is this is catalytic, right? That philanthropy in some ways is taking the first big leap or the risk that might then incentivize government where there is, billions and billions of dollars to sort of absorb your programming and scale it even further.
I think this very much resonates with what's changed for us as well. 2 or 3 years ago, we knew the science. 30 services could save 30 million lives by 2030. We knew where the deaths are happening. 9 million deaths, as I mentioned before, mainly in rural communities in 73 low and middle income countries across Africa, Asia, and the Americas. So we knew the solution, we knew where the problem is, but you could only scale one country at a time. And what's going to happen here is we'll have 4 or 5 exemplar countries where governments are leading this, local domestic governments are leading this. But then how would you get to 73 countries? Ultimately, government's going to be key. And if you look at the science around this, there was a paper in Harvard Business Review in October called Audacious Philanthropy, written by Abe Grindle, who leads another important philanthropic collaborative called Co-Impact, by Olivia Leland, who formerly directed the Giving Pledge. And what they found, looking at big bets in philanthropy, is that if you wanted, when the car seat movement came forward, and when 911 was introduced, when free school lunches were provided for low-income students across the country, every one of those big changes came from 1, big bets, 2, collaboration, pooling resources, 3, making sure that there was actually long-term engagement. The median time was 45 years to see that change. And lastly was this collaboration with government. Either policy had to be changed, action had to be changed, or some kind of other reform had to happen with government cooperation. So what we're finding now is that government's key. So we have been able to launch a community health academy along with groups like Josh's, Living Goods, and about 15 other organizations working across 15 countries in Africa, Asia, and the Americas. And it's ministries of health, government leaders that are working with us to create a common curriculum that would help ensure that health leaders of today in those countries and health leaders of tomorrow can understand how to better design and build community health worker programs in their own countries. And we're taking a big risk. We're using an online platform, a massive open online school platform with Harvard and edX, and pairing that with local universities in Africa and West and East Africa to try to build that. That's not something we've ever done before. It's a new initiative. We wouldn't be able to take that risk were it not for this kind of big philanthropy.
Great. Robyn.
Yeah, I mean, Elma's been doing philanthropy for almost 14 years now, and by doing this kind of collaborative style philanthropy and working with others, we're just able to step up our game. I mean, we're primarily Africa focused, and Africa is facing a lot of challenges. So working together with other philanthropies enables us to take those on in a much bigger way. It also, to your point, Lindsey, about the role that philanthropy plays in being catalytic, we can be more catalytic when we're working together because we're pooling our resources. We become stronger. We become a much more formidable force in the field of social change. We can go to the World Bank and say, hey, we're putting in $50 million to expand community health workers across Africa. What are you doing? Can we do it together? We can go to the UK's aid organization and the US government's aid organization and say, hey, we're going to get rid of trachoma in 10 countries in Africa. There's a little bit more to be done. You've been working on this for a handful of years. Do you want to partner on that? We're coming with $100 million. Let's talk. It opens up doors to these much larger players and funders than we could have access to if we were just out there trying to do this on our own.
So I think we're hearing a lot about possibility, but you're also doing things that haven't been done before. So maybe each of you could talk a little bit about any challenges that you're experiencing in a universe where you've gone from single play to team sport, and of course maybe balanced against what the benefits of that is.
I can jump in here.
Please.
I think one of the, philanthropies and foundations and philanthropists are very unique beings and entities with their own set of priorities, their own ways of doing things. So when you try and bring a group of these strong personalities and unique organizations together, there's inevitably going to be challenges, right? What reporting template does the Gates Foundation use, and how does that differ to what Elma uses? So there's certainly a bit of a heavy lift around trying to coordinate all of these different players, but I personally think that it's worth it because, and please correct me if I'm wrong, but the way I see it is it seems to be freeing up our grantees, like Raj and Last Mile Health, to really focus on the business of social change and implementing their bold vision. Because let the philanthropists figure out all that stuff of coordinating single reporting, agreeing to accept one proposal. It frees up our grantees' time so they don't have to spend Raj doesn't have to spend all his time fundraising, going door to door, asking, let's do it together. And let's coordinate our reporting so that so Raj and his team can really focus on implementing this bold vision. So it's certainly challenging. There's a lot of unique personalities in this space, but it is worth the heavy lift because we are able to be better philanthropists and better enabled, play an enabling role in supporting social change.
Josh, Raj?
I don't have much to say. I honestly think that the benefits so far outweigh the challenges.
Yeah.
And that's probably where I'd leave it.
I agree, and I think that's right. I think the other thing is that when you hear these big bets announced, two things can happen. Is that you could almost be fooled that the problem's solved, and you can also be fooled that that it takes only 6 or 7. That you need to have a net worth of 30 or more million to make a difference, and that if you're giving $50 or $1,000 or $10,000, you no longer matter. I think both of those are myths, and the science and the math just shows it. I mean, Josh already mentioned, to get all the primary health care needed in the poorest countries in the world is going to take about $33 billion of new funding in the next 12 years to get to 2030. That's on top of the billions that's already needed now, needs to be better directed. So tens of millions is great, hundreds of millions is better, but that money has to be used catalytically, And there's a role for everyone to play in that. The second thing is that actually what we have found for funders who have maybe less wealth, the wealth can actually be, and the donations can actually be used actually more creatively, because we have now a multi-year funding landscape. We can look 4 years out. It allows us to do things like, with Sandra and Sam, we've built a maternity waiting home. In Liberia, why does that matter? There's in the last few years, several hundred women died because they never even reached the clinic because they were stuck in labor or they bled to death in their homes because they're hours away. Well, we know maternity waiting homes can matter. That's not part of the government policy right now. So some of the funding they've provided allow us to create a maternity waiting home. That waiting home and a few other groups that have done it across the country had 584 mothers that delivered in next to clinics. These are homes that are built next to clinics so mothers can come in there at term and stay near the clinic, so when they go into labor, they can be served by midwives and physicians and others. Well, 584 mothers in the year 2017 delivered babies after staying in maternity waiting homes. None of those mothers died. None of those died. So we can't do that unless others come in to build on this effort. So I think that's the other big challenge.
All right, we're going to do 2 more things from the panel, and then we're going to open this up to the audience. All right, so panel. Robyn, you raised something over breakfast this morning, and it dovetails off of what Raj was just saying about who can participate in a big bet. Because we have been talking about well-established philanthropies, but why don't you give the example of what's going on right now? And that's going to lead to our last question. Who can make a big bet?
Sure, yeah. So some of the examples we've just shared have been, kind of a handful of philanthropists making a massive bet, but really everyone can do this kind of group-style philanthropy and take on, a social problem. And so the example that we were talking about is this fundraising campaign through Facebook that just happened last week, where a couple in California created a fundraising campaign on Facebook to raise, I think they started out, when I donated to it personally, they were trying to raise $150K to go to an organization called Raíces in Texas that is working to provide legal aid and other services to families that are caught up in the brutal immigration system that's been made more brutal by the current president of the US. And they were seeking to raise $150,000 by the end of the week. So I think I donated on Monday, and by Friday they had raised $20 million from 500,000 people. That's an average donation of $40. So for me, that just is such a beautiful current example of how this big bet philanthropy, doing it together, doing it in aggregate in a team-based way, can happen at every level of society, and really everyone can be a big bet collaborative philanthropist, and that example to me showcases that.
Mm-hmm.
So everyone here in the audience is just settling in for what's going to be an extraordinary week of ideas, thanks to the Aspen team. If you can leave the audience with one thing, if you want them to remember one thing from this panel, what would you like them to remember?
I would say that it's something my dad taught me, which is no condition is permanent. And it's something he'd say all the time while we were growing up in North Carolina, but it's something I've come to embody with our work and lean on. Illness has been universal for all of human history. Access to care hasn't. A lot of the big problems that we all care about have been chronic long-term issues that may be centuries old and seem like they can't be solved. But they can be. And even if our dreams scare us, because they will if you try to go after them, I think what I found is that if we commit to go after them together, we can go further than we've ever imagined. So my hope for all of us is that we commit to go together because we can go further.
Raj always ends with such inspiring words, but for me, I think, the takeaway is to really collaborate. That there are a few individual geniuses out there that can do it on their own, but for most of us, we need to do it in groups. We need to do it in a way where we're learning from each other. And another thing we were talking about earlier over breakfast is that in these big bets that we've been describing on the philanthropy side, the people that have been executing these big bets have, by and large, been women. And so I think there's also something worth noting about the fact that collaboration is a decidedly feminine way of working, and this is disruptive to philanthropy, which, like many sectors in our country, in our world, are male-dominated and dominated by masculine ways of doing things. So Lindsey and I and all of us were reflecting on how cool it is that there's this kind of feminine way of doing philanthropy that's picking up speed and gaining momentum, and I just think that's an awesome observation, and I'm so thrilled to be able to be part of that and learn from these really incredible women philanthropists and the awesome men that are in our group too.
No, right on. I mean, as a feminist, I was going to say the same. I think that a feminine way of collaborating has made its way and has really lived for a while within what is now a self-organizing group of organizations or collaborators. Anyways, I think it's inspiring. What I hope that we remember from this, in addition to that, is just simply moonshots for people. Yeah. We need more moonshots for people. And I love philanthropy as a term, and I love just reflecting on like what things could or should be done, just considering our love for humanity. Then fill in the rest from there. So more moonshots for people.
I'll close with my hope. And you said could or should, and I'll change out that word and put in will. Will is such an underappreciated concept, but it is extraordinary. You are sitting and learning from people who have the most unbelievable will to go make things happen in the world, and each one of us has it inside of us. And so it's not about the wealth. It's not about but it starts from a very basic belief that change can happen, and every single person can be a part of affecting that change. So with that, our panel is going to open up to questions. Can I have a mic runner, please, up to the front row? This young woman in the hat, please.
I'm Mitzi Worth. I'm now with Enable Postgraduate School. From 1970 to 77, I ran the Cafritz Foundation in Washington. I tried to do this collaborative work. I'm so glad you've been able to make it happen. I have a question about people in need, which was an article I read yesterday about how in our Midwest, a lot of the communities don't have access to dentists or doctors. How do we address those as well?
Great, thank you. Raj, you want to start?
Yeah.
It helps to have a doctor on the panel. This is a very handy tool.
Well, and Mitzi, I don't pretend to have the answers. I think what I can share is what I've seen working in some places in America. The first place I actually learned about community health workers was not in the country I was born in. It was a country that took me in. I went to Alaska when I was 20 years old and got to see this extraordinary program in rural America that trained community health workers for 50 years, people in fishing communities across the tundra in Alaska. 20% land mass of the US, very hard to get doctors out there. And by the time I was there, after 50 years after this program had started by the state of Alaska, it's called the Alaska Community Health Aid Program, they were training local women and men who had been trained maybe 16 to 32 weeks to do dentistry care and to do everything like you might in your primary care clinic around here in Aspen even. Well, here's what happens when you try to push for that. When you break the guild mentality in medicine, when you try to take power out of the hands of doctors and you shift it, you get some resistance. And I think in the case of the Alaskans, they were sued by the American Dental Association and the claim was it's not safe, not effective. Again, to resist that, they used data and science. Safe, effective, high quality is what they showed, monitored by dentists remotely using technology and telemedicine. The ADA lost their case, and in the write-up around it, the Alaskans also pointed out there had been 40 vacancies for 40 years that no dentist came to fill. So I think part of it is going to be hiring, employing, reskilling people in our country here to be part of the medical team. And we as doctors need to start teaming up with community members to do that.
Great. Other questions? And by the way, Mitzi was like a perfect role model on stand-up, intro, quick question to the panel. So we have lots of hands. In the back of the room in purple.
Thank you. My name is Kakeja Ntaya, and I run an organization that supports girls' education in Kenya. Very, very good discussion. I have 3 things to say. One, you talk about
We hope one is a question, yes?
All of them is actually questions because
terrific.
it's concern. So one is when you talk about scalability, are you thinking about the quality? Because what you said is that you have to spend depth to be able to have the quality. And that comes, you can talk about scalability and how you're going to maintain the quality. The other thing, you talked about the online platform. I hope you're maintaining the mobile and not the computers, because if you're talking about the last mile in the rural communities, there's no electricity, you know all that I'm talking about. And the other thing is about governments. We're very attracted to work with governments, but like mine, we're very corrupt. How are you going to ensure that your resources and the effort that you're putting into that, the work that you're going to do, is actually going to reach to the people that you want to get to?
These are great questions. So scalability, make sure the technology is actually appropriate, and how are you thinking about effective partnerships with government?
Maybe I'll start with quality, that question, and I'll take it a step further and just to go there, I'll add equity. So there's huge risk when we scale that we look at numbers, we look at metrics, and we design entire systems towards those metrics. If one of those metrics is not quality and another metric is not equity, how is that system performing for subpopulations, those who have been most marginalized by status quo systems? If that is not a metric that accompanies every step of scale up, and if we aren't looking at those metrics every single month at 5 or 6 different levels of the system, it's not going to work. So I think it's a great question.
Mm-hmm.
And maybe about the technology, just a reassurance that.
Yeah, we've got to meet people where they are and design things with them. And the devices that you use, the user experience, it's amazing. People give you answers to what seem like hard questions about each of those technology decisions. And let's see, a system is beautiful when it works and it achieves results for people, not if the promo looks good.
Great. And Raj, how about government partnerships?
Yeah, I was going to ask Robyn, you guys have done a lot of work with governments. Do you want to answer that one about public health and why working with governments would actually reach the impact that you're intending?
Yeah, so ELMA actually, a lot of our partnerships and work in Africa is in partnership with government. So we're not necessarily funding government directly, but we do ensure that what we're investing in is related to the government's priorities. And the reason why is because the way you actually get scale, in my opinion, is either through the market, through the market, or through the public sector and through government. So we have a team. About half of our people are based between South Africa and Uganda, and spend a lot of work, a lot of their time building relationships with government and making sure that what we're funding is in line with their priorities. With regards to corruption, one of the value adds that ELMA brings to a philanthropy collaborative is that we have a very rigorous financial due diligence process. Raj knows about it because he's been through it. And also, we have a very robust financial monitoring and reporting process that includes doing financial audits. So we're very, very hyper-focused on making sure that our resources are getting where they intended to get to, and we're also focused on ensuring that we're not just investing in like small-scale pilot projects, but actually things that change makers in governments want to take to scale, and we do those in partnership with them. We've done it in Liberia, we do it in Ethiopia. I have tons of examples I can tell you about after the panel.
Great. Other question? Yep, right here, plaid shirt.
Chip Edens, I'd like to get you to just talk about the nuance between charity and justice. And in the description, it speaks of addressing an unjust system. And so not an inefficient system, but an unjust system. So I'd like to hear about how you've leveraged your assets, whatever those assets are, to actually change an unjust system.
Yeah, I'm happy to
Go for
answer.
it.
Thank you, Chip, for that. Probably the most unjust barrier to getting healthcare within reach of everyone, everywhere, especially in rural parts, I'd argue here in developing countries, is this notion that if a community health worker should be a volunteer. The great majority, the truth is, and it's scandalous, is that the great majority of community-based providers in the world are either volunteer or semi-compensated. They don't have a real job, a real career path. So one of the things we did in Liberia about 7 years ago was to go to the government and say, you're not getting great results out of this. It's not, who would work for no pay? None of us do. Why should they? But what could we do to demonstrate a change in that changing the policy to pay them, to give them jobs, might make a difference? They actually gave us real answers to that. Show us if you pay them $70 to $80 a month, what happens? Add a coach nurse, give them a better set of medicines and training. And we found a 50 to 60% increase in treatment access. Mothers were now delivering in clinics. And so then they reformed their policy based on that data. Today, there are 3,000. We started with 30 in that demonstration project. Today, there's 3,000 paid, employed rural community health workers, women like Serena, across the country. It's the largest jobs program in the health sector. Most of the people think a health sector is sort of wasting or costing something. This is an investment in rural jobs in a country that has 85% unemployment, and we think it needs to happen across the world.
It's a great example. All right, I think we have maybe 2 more questions. James, up front.
Some of the answers that you guys... My name is James Markle. I'm with GoSun, developing gay community, gay male community in America. Some of the answers that you've given have sparked interest for me. I'm curious to know, going into a country, giving technology, giving jobs, asking people to step into their neighbors' homes, possibly strangers' homes, is there time, energy, and money going into seeing like ripple effects? Because obviously the focus here is money, but that also seems to me like that would also be benefiting community, trust in that community, respect in that community. Are there any programs that are witnessing kind of the ripple effects of, even though the focus is medicine, the result might be trust, community?
Yeah.
The living goods.
I was just,
Yeah.
you want to
no,
tell
go-
that story? No, go ahead. I think probably.
No, you probably have the facts better than, well, shall I start and you, okay, correct me if I'm wrong.
I think you should.
So one of the organizations that is working in this partnership we just described of building 50,000 community health workers is Living Goods. And actually, so in the Living Goods model, most of the community health workers are women. And this obviously, well, not obviously, but I will just add a point here that Living Goods model was rigorously evaluated and shows a 25% reduction in child mortality. So I just wanted to mention that this model works, it saves lives. But in addition to saving lives, these women in the Living Goods model have a greater prominence in their community, and many of them have actually run for local elections and won, and that's something they would have never, that wasn't even in the realm of possibility, but by going door to door and having, and gaining the respect from their community and from families that are literally, lives are saved because of them, they were able to get the confidence and vision for themselves and their community to actually run for local office. So thank you for asking that question, because the ripple effects of this model on employment, on women's empowerment, and on healthcare and many other things is really fascinating and should be better studied and shared.
Are you also recommending it's part of the 2020 presidential election campaign, going door to door, having people do healthcare as part of planning?
Yes.
Okay.
Well,
yeah. Don't want to
yeah.
put words in your mouth.
Lindsey, I just want to say, James, I love that question, and I think it might bring extra hope to know that what I've seen Raj and many others do is start designing a health system from the social networks, from the pockets of trust, up. And I really hope there are a few bright spots in the US, but no one in a big way is trying this. I actually really hope that Atul Gawande and a few others who have all the resources that they need to try to do something like that, to give people meaningful full work and co-develop meaningful jobs, starting from trust as an asset and something that they've built over their whole entire lives with their community members, and designing the health system from there.
I think we have time for one last question. Sure.
Thank you. I'm Ethan. I run a clean energy company in sub-Saharan Africa called BioLite. Sorry to end on this, but what if you make the wrong bet? So in the clean cooking sector, a foundation invested $30 million in a company, and 10 years later, the sector would say that was the wrong investment. And I have concerns on a couple levels. One, do these organizations have the carrying capacity to take on $50 or $100 million? I think with that scale of capital, our organization would get sloppy. Number two, does this crowd out other innovations and competition inside the specific sectors? And then number three, the opportunity cost of a big bet philanthropy is a diversified portfolio of investments across a sector. And I'm just wondering how you think about that.
Can I
Yes.
try that? Okay. So a lot to say. Number one, do we worry about something not working? Absolutely. We don't want to fail. There are lives at stake. But there's a few things. One, failure is not always a bad thing, because hopefully we will learn from it. When we're doing things collaboratively, we'll learn from each other. And number two, by doing things collaboratively and from the philanthropy perspective, we're sharing risk. So if Raj came to me and said, I need $100 million, I wouldn't want to concentrate our Elma's philanthropy and our risk into one idea. So by doing it in this collaborative way, we're able to kind of diversify our risk, much like a venture capitalist would. The second thing I wanted to comment on is the opportunity cost, right? Or you said something about concentrating your risk. So I wanted to point out as well that if we're putting in 10 million, let's say, into this $100 million plan to scale up community health workers, we're also making that size or smaller bets across multiple types of different organizations and initiatives. So we have a diversified portfolio. We're not putting all of our eggs in one basket, and we're able to do that because we're doing it in partnership.
And just to add on to that, Robyn, I love that. From my perspective, inaction at that level of scale is the scariest thing by far.
Yeah.
Yeah, I mean, I will close out the panel officially to say, to me, the biggest failure is inaction. And I want to thank the courage of our panel for everything that they're doing. Great questions, great audience, and thank you very much. Enjoy the rest of your festival.